Hi everyone, welcome to MedEd Mastery. Today I am going to explain about tuberculosis, commonly known as TB. Tuberculosis is caused by infection with mycobacterium tuberculosis, which is part of a complex of organisms including M. bovis, reservoir cattle, and M. africanum, reservoir humans. Mycobacteria are acid-fast bacilli. Mycobacterium tuberculosis is spread by the inhalation of aerosolized droplet nuclei from other infected patients. Once inhaled, the organisms lodge in the alveoli and initiate the recruitment of macrophages and lymphocytes. Macrophages undergo transformation into epithelioid and Langhans cells, which aggregate with the lymphocytes to form the classical tuberculous granuloma. Numerous granulomas aggregate to form a primary lesion or gone focus, which is characteristically situated in the periphery of the lung. Spread of organisms to the hilar lymph nodes is followed by a similar pathological reaction. Reparative processes encase the primary complex in a fibrous capsule, limiting the spread of bacilli. If no further complications ensue, this lesion eventually calcifies. Gone focus, it is primary lesion characterized by aggregation of numerous granulomas in the periphery of the lung. Gone complex, it refers to the combination of gone focus and hilar lymphadenopathy. Rank is complex, it is formed when gone complex undergoes fibrosis and calcification. Latent tuberculosis is a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens, with no evidence of clinically manifest active TB. Primary TB refers to the infection of a previously uninfected individual. It is usually asymptomatic. When primary infection occurs, it may remain dormant for years in more than 90% of the cases, so-called latent TB, or it may progress to progressive primary TB in 10% of the cases. If the immune response is incomplete, then primary infection may progress and the pulmonary and constitutional symptoms of TB may occur. This is progressive primary TB. Miliary TB refers to the dissemination of tubercle bacilli through bloodstream. It is characterized by 2 to 3 weeks of fever, night sweats, anorexia, weight loss, and a dry cough. Hepatosplenomegaly. Headache that may indicate coexistent tuberculous meningitis. Fundoscopy may show choroidal tubercles. The classical appearances on chest X-ray are of fine 1 to 2 mm lesions, called millet seed, distributed throughout the lung fields. Anemia and leukopenia reflect bone marrow involvement. Cryptic miliary TB is an unusual presentation, sometimes seen in old age. Disseminated tuberculosis, TB, is defined as mycobacterial disease that has 2 or more non-contiguous sites resulting from hematogenous dissemination of Mycobacterium tuberculosis. It may result from progressive primary infection or occur via reactivation of a latent focus, with subsequent spread. The term cryptic disseminated TB describes patients who have disseminated TB with less typical chest radiographic abnormalities, including normal and non-miliary pattern. The features of cryptic disseminated TB are: age over 60 years, intermittent low-grade pyrexia, unexplained weight loss. Normal chest X-ray. Blood dyscrasias, leukemoid reaction, pancytopenia. Negative tuberculin skin test. Confirmation is by biopsy with granulomas and/or acid-fast bacilli in liver or bone marrow. Also known as post-primary pulmonary TB. Post-primary disease refers to exogenous, new infection, or endogenous, reactivation of a dormant primary lesion, infection in a person who has been sensitized by earlier exposure. It characteristically occurs in the apex of an upper lobe, where the oxygen tension favors survival of the strictly aerobic organism. It occurs when host immunity is weakened. Systemic symptoms include fever, night sweats, malaise, and loss of appetite and weight, and are accompanied by progressive pulmonary symptoms. Radiological changes include ill-defined opacification in one or both of the upper lobes, and as progression occurs, consolidation, collapse, and cavitation develop to varying degrees. It is often difficult to distinguish active from quiescent disease on radiological criteria alone, but the presence of a miliary pattern or cavitation favors active disease. The risk factors are immunosuppression like in HIV, malignancy, especially lymphoma and leukemia, diabetes mellitus, chronic kidney disease, overcrowding, smoking. The clinical features of pulmonary tuberculosis are chronic cough, often with hemoptysis, pyrexia, unresolved pneumonia, exudative pleural effusion, weight loss, spontaneous pneumothorax. Extrapulmonary TB is more common in HIV-positive patients. The clinical features of extrapulmonary TB are: Number 1, lymphadenitis. Lymph nodes are the most common extrapulmonary site of disease. Cervical and mediastinal glands are affected most frequently, followed by axillary and inguinal. The nodes are usually painless and initially mobile, but become matted together with time. When caseation and liquefaction occur, the swelling becomes fluctuant and may discharge through the skin with the formation of a collar stud abscess and sinus formation. Scrofula refers to massive cervical lymph node enlargement with discharging sinuses. Number 2. Gastrointestinal tuberculosis. Ileocecal disease accounts for approximately half of abdominal TB cases. Fever, night sweats, anorexia, and weight loss are usually prominent, and a right iliac fossa mass may be palpable. Ultrasound or CT may reveal thickened bowel wall, abdominal lymphadenopathy, mesenteric thickening, or ascites. Barium enema and small bowel enema reveal narrowing, shortening, and distortion of the bowel, with cecal involvement predominating. Diagnosis rests on obtaining histology by either colonoscopy or mini-laparotomy. The main differential diagnosis is Crohn's disease. Tuberculous peritonitis is characterized by abdominal distension, pain, and constitutional symptoms. The ascitic fluid is exudative and cellular, with a predominance of lymphocytes. Laparoscopy reveals multiple white tubercles over the peritoneal and omental surfaces. Number 3. Pericardial disease. Disease occurs in two forms: pericardial effusion and constrictive pericarditis. The presentation is usually insidious, with breathlessness and abdominal swelling. Pulsus paradoxus, a raised JVP, hepatomegaly, prominent ascites, and peripheral edema are common to both types. Pericardial effusion is associated with increased pericardial dullness and a globular enlarged heart on chest X-ray, and pericardial calcification occurs in around 25% of cases. Constriction is associated with an early third heart sound and, occasionally, atrial fibrillation. Diagnosis is based on the clinical, radiological, and echocardiographic findings. The effusion is frequently blood-stained. The addition of glucocorticoids to anti-tuberculosis treatment has been shown to help both forms of pericardial disease. Number 4. Central nervous system disease. Meningeal disease represents the most important form of central nervous system TB. Other features are hydrocephalus and space-occupying lesion, tuberculoma. Number 5. Bone and joint disease. The spine is the most common site for bony TB, so-called Pott's disease, which usually presents with chronic back pain and typically involves the lower thoracic and lumbar spine. The infection starts as a discitis and then spreads along the spinal ligaments to involve the adjacent anterior vertebral bodies, causing angulation of the vertebrae with subsequent kyphosis. Paravertebral and psoas abscess formation is common and the disease may present with a large, cold, abscess in the inguinal region. The major differential diagnosis is malignancy, which tends to affect the vertebral body and leave the disc intact. Complications: spinal instability or cord compression. TB can affect any joint but most frequently involves the hip or knee. Presentation is usually insidious, with pain and swelling. Ponson's arthropathy is an immunologically mediated polyarthritis that usually resolves within 2 months of starting treatment. Number 6. Genitourinary disease. Hematuria and dysuria are often present, with sterile pyuria found on urine microscopy and culture. In women, infertility from endometritis, or pelvic pain and swelling from salpingitis or a tubo-ovarian abscess occurs occasionally. In men, genitourinary TB may present as epididymitis or prostatitis. This is the end of part 1. The complications, diagnosis, and treatment of tuberculosis will be discussed in the next video. For more videos like these, please follow us on YouTube.